Welcome, everyone, to the HSC Office for Diversity, Equity, and Inclusion LGBTQ plus Pride Month event. My name is Dr. JP Sanchez. I serve as the acting vice president of the office. On behalf of all of us in the office, as well as our vice president, Dr. Romero Leggett, we would like to thank you for making time to join us. For those of you who are not able to join us here today, this presentation will be recorded and posted on our HSC Celebrations website. Before we begin, I just want to go over a couple of housekeeping items. We will be using a Zoom webinar format that does not allow participants to address the panelists directly, but rather through the Q&A function. The chat feature is also not available. Please place your questions in the Q&A box at the bottom of your screen. We will try and address as many as we can at the end of the presentation. You can see the panelists, but the panelists cannot see you. And please also take a moment to complete the pre-assessment in the chat box. This will help us understand your interests and reflections during the month. I also want to note that towards the end of the presentation, you will also receive a post-assessment to get your reflections on the workshop. And so with that, I would like to welcome and introduce our own Shirley McLaughlin, who serves as our Associate Dean of Health Professions Programs in the School of Medicine, as well as our Interim Director of Students and Student Support Services at HSC.
Thank you so much, Dr. Sanchez. It's also my pleasure to be here today. I would like to introduce my colleague, Dr. Kevin Schroeder. I just really quickly want to give you a little background on the partnership that we have with the Office for Diversity on the interprofessional education team, the interprofessional education team being part of the Student Services Office. We work very careful, very close on so many important activities with the Office for Diversity, and they have, we're honored to be able to partner with them today on this presentation. You may see in the chat that we put in a survey for those of you. I know we have many students that are doing this for the interprofessional education honors. Please don't forget to also, not asking you to do one more survey, but please don't forget, we want to give you credit for your participation today for the interactive category. So just as a reminder to fill that out as well. Well, for the sake of time, I want to get to the most important part of today, and that is to introduce my colleague, Dr. Kevin Schroeder. Dr. Kevin Schroeder is the coordinator of clinical education, and he is also a lecturer within the University of New Mexico's professional athletic training program. Prior to his time at UNM, Kevin was an athletic trainer himself with the 351st Battlefield Airman Training Squadron, a special operations squadron at Kirtland Air Force Base here in Albuquerque. He has also previously served as an athletic trainer at the Olympic Training Center in Colorado Springs. He also worked primarily with combat sports, including wrestling, boxing, judo, Paralympic athletes. He was a member of the 2015 Parapan American Games medical staff in Toronto, Canada, and in the 2016 Paralympic Games in Rio de Janeiro, Brazil, where he worked closely with the Paralympic judo team. So that means don't mess with Kevin. He's also worked clinically in the Arena Football League for the NCAA divisions 1 and 3 levels. Also, Kevin is a graduate of the East Carolina University with a Bachelor of Science in Athletic Training, and the University of Pittsburgh with a Master of Science in Health, Rehabilitation, and Sports Medicine Sciences at the University of Idaho with a doctorate in athletic training. He's also a Distinguished Practitioner Fellow of the National Academies of Practice, a peer reviewer for the CAATE, the District 7 representative for the National Athletic Trainers Association's LGBTQ plus Advisory Committee, and the Vice President of the New Mexico Athletic Trainers Association. His research interests include qualities and challenges facing the LGBTQ patients and our healthcare providers, and interprofessional healthcare education and practice. So it is my great honor and pleasure to pass this off to my wonderful colleague, Dr. Kevin Schroeder.
Thank you, Shelley, and thank you to the HSC for allowing me to speak today. This is a topic that's near and dear to my heart, so I'm looking forward to this. Briefly, I don't have anything to disclose, but I would like to give a quick shout out to one of my colleagues and good friends, Dr. Danny Moffitt, who helped to co-create this presentation that I am fortunate enough to share with you today. We're going to talk about basically how to take your clinic and turn it into a place that is supportive and welcoming to all the patients that we treat through various different mechanisms that we'll talk about as we move through the next several slides. So I want to start real quickly with a brief activity. And on a scrap sheet of paper, on your phone somewhere, I want you to take a few moments and just write down, and you're not sharing this with anyone, this is private just for you, but real quick, write down what your gender is, your political affiliation, maybe your religion or spirituality, what your ethnicity or race is, and your sexual orientation. And again, this is not being shared with anyone, and you can put these in any order. In fact, I want you to randomize the order that you put them down. And once you've done that, I want you to randomly number them 1 through 5. It doesn't matter which number goes to which one, because what we're going to do, or what I'm going to do rather, is I'm going to say that you no longer get to hold affinity towards or identify as numbers 2, 3, and 4. So now all you're left with is number 1 and number 5. And as you sit here stewing on the idea of me removing 2, 3, and 4, leaving you with just 1 and 5, I want you to think about the feelings that you have. Maybe you feel angry or sad or distraught, and understand that these are the same feelings that a lot of patients have when they walk into places or listen to the news or overhear conversations of nearby people talking about aspects of their identity. And this kind of just scratches the surface as to why we need to have safe spaces across the board, including in our clinics. And so we talk about things like being an ally and being an advocate. And I want to break down really quick the difference between those two words. And so an ally is a term that we utilize to describe someone who's actively supportive of, in this case, the LGBTQIA plus population. And for the purposes of this talk, instead of me keep on saying LGBTQIA plus, because it's a mouthful, I'm going to refer to it as the community or the queer community or queer people, but understand that it's a very inclusive term. And so an ally can be anyone. It can be a straight person, it could be a cisgender person, it could be someone who's within the queer community, supporting other aspects of the queer community. But we're simply getting at the point that the word ally is a noun. The flip side is the word advocate, which is also a noun, but it's also a verb. It's action-oriented. And so I want you to take a moment and think for a moment, what are some of the things that you advocate for in your life? And I don't necessarily mean other people, but it could be other people. It could be maybe your kids if you're a parent, or another loved one. We advocate for rather silly things. If we have we order food at a restaurant, it comes out wrong. We advocate for ourselves to get something correct because maybe food was brought out with an allergen on it or something along those lines, right? We advocate all the time and we may not realize it. So what we're trying to approach today is bringing forth those thoughts of advocacy into our clinical practice. And so while this presentation will focus probably more on queer individuals, understand that there are overlap between ethnic and racial minorities or other individuals that are historically part of marginalized groups. So why do I need to be an ally or an advocate? Well, if we look at it from an ethnic or racial minority perspective, we know that ethnic minorities, racial minorities have less access to and availability of healthcare services. They're less likely to receive needed healthcare services. They're less likely to receive high quality healthcare services. And there's experience a greater burden of disability across the board. The Surgeon General report from 2001 quoted, "A disturbing new study by the Institute of Medicine has concluded that even when members of minority groups have the same incomes, insurance coverage, and medical conditions as whites, they receive notably poorer care. Biases, prejudices, and negative racial stereotypes," the panel concludes, "may be misleading doctors and other healthcare professionals." It has been known for 20 plus years that these attributes of individuals can simply be a barrier to quality healthcare. If we look at queer community members, nearly 1 in 6 queer patients experience discrimination in healthcare settings. 29% of transgender patients have been refused to be seen by a provider. We also know that queer individuals delay or avoid care. 1 in 5 queer individuals have identified as avoiding to seek care. If we look at patients that are in schools, secondary schools, middle schools, high schools, that we know that these settings are unsafe, that they are promoting unsafe behaviors towards queer individuals. Homophobic slurs have been heard by over half, at 65% of individuals. 85% say that they've been verbally harassed just within the past year. And as a result, we know that there's worse educational outcomes for individuals who identify as part of the queer community, such as lower GPA, less likely to go to college, have lower self-esteem. So when we don't advocate, what are some of the things that occur? And so we know that there's miscommunications that occur between the provider and the patient, which could ultimately leads to misunderstandings between provider and the patient, which leads to medical mistakes, and poor health outcomes. And so we need to understand that communication is a key cornerstone of what we're going to talk about today, and ensuring that how we communicate, why we communicate, is done in an effective way to help promote quality patient outcomes here. So if we look at the latest US Census data here, this is all from the 2020 census, that by 2043, the so-called minority populations of the United States are actually going to become the majority. But understand that no single group will make up the majority, meaning whites will not be 50%, but they will still be the largest group. Non-Hispanic whites, or excuse me, by 2060, nearly 1 in 3 Americans will be Hispanic. Understanding that that term is what's being used by the US Census. Black Americans will increase to 14.7%. Asian Americans will double to about 8.2% of the total population. We look at African American, Hispanic, and Indigenous peoples and how they make up 25% of the US population at the present moment. 12% of individuals have identified as disabilities, and 9 million Americans identify as LGBTQIA+. Sorry, I'm in the middle of something. Sorry. So how do we get to the point of being an advocate? Patient values is really the cornerstone here, what we're going to talk about. So we have to understand that when our patients come into our clinic, when they cough to the door, there's something underlying that we need to understand so we can get a better understanding of who they are as a person, beyond just the pathology that brought them through our door. And so patient values can even be defined pretty broadly. Things such as features that matter most to the patient, to something a little bit more complex, like the unique preferences, concerns, and expectations each patient brings to a clinical encounter, and which must be integrated into clinical decisions if they're to serve as the patient. So we have this intersection of the patient identities with our patient values with our own self-identity. And how do I, as the provider, intersect with the values of my patient? And so I want you to stop and think for a second and think to yourself, what makes you diverse? Are you diverse? And if so, how? And what groups do you identify with? And do these groups reciprocate that identity? Do they see the same things that you see yourself as in their group? And how do you take advantage of cultural enrichment opportunities? Because your answers to these questions help to formulate your responses to indications with other patients. And so we can really dive into patient values. We're not going to spend a ton of time on this today because this is a whole nother talk here, but the Schwartz theory of basic values comes into play here, in understanding that what is important to the patient may not be important to me as a provider, and vice versa. But we have to find a commonality or an intersection point between values and all parties involved. One really easy way to do this, and I've done this before in my clinic, is the Wordle, which is a kind of like a word cloud of things that I use to describe myself. So I used to put this on my clinic door so that when patients walked in, they could see some things that I value as a person, right? Not as a provider, just as a person. You know, I'm an educator. I'm gay. I have a husband. I'm an ally. I'm a learner. I love to read books. These are things that my patients can read and understand and appreciate. Like, oh, well, I also like to read books, or, oh, I also have a dog, and find commonalities and understand that this is the beginning of them stepping into what we consider to be a safe space. And please start to understand too, that what we're talking about here is just the tip of the iceberg, right? What we know as patient values, and that there's so much more to people than just what we get to know in the 5-minute, 10-minute, 15-minute encounters that we have with them on occasion. As an athletic trainer, I'm fortunate enough that I usually get to see my patients every day, every other day, because they're coming in for various sports medicine needs, whether it's coming in for some kind of rehab before practice or some kind of care after a traumatic injury during a game, whatever it may be. And so my encounters might be a little bit different, but I still don't get to know them in totality because people change and evolve over time. And so we're dancing around this idea of intersectionality, and that patients are more than just the ankle sprains or the diabetes, or pick your pathology that they're coming into, right? And we have to recognize and appreciate all of these different aspects, whether or not they seem to have a strong presence in treating them at that moment or not. One of the things we can look at is, I love this graphic. It's called the genderbread person. You can find this online. There's even a unicorn version of this. There's various aspects of this. But what this is getting at is that, again, intersectionality here, that gender identity, gender expression, and anatomical sex are three mutually exclusive things. That just because one is one thing doesn't mean that the others have to be something else. Sexual attraction, romantic attractions can be two separate things. And so understanding this and putting forth the effort to integrate this into our clinical practice can help benefit the patients that we treat. And so we need to, again, to continue to this, I look at this intersection of patient values and being an advocate, and understand that this isn't a clearly defined process, that there isn't, okay, I've hit step one, now I'm going to move on to step two. Step two is complete, on to step three, that we ebb and flow backwards and forwards as we start to learn more about the patients we treat and meet them at their level. So let's dive a little bit more deeply into identity. And so I want you to think for a moment, what are some of the racial or ethnically identities that your patients present to you with? It could be something as straightforward as Hispanic or Black or Native American, or maybe they're a mixture of all of these things where they grew up in a home that might identify as Hispanic, but they have some Indigenous or Native American, using their words to describe what they prefer to be utilized, but from a cultural perspective. And what groups do you serve, and do you serve them regularly? And how can you improve your care to these patients? Thinking about some of the characteristics of some of these individuals. Are we treating patients that are homeless or housing insecure? Are we treating substance use and abuse? And if so, how do we integrate understanding that they may not be ready to address some of these issues at this moment in time, yet they're still a big part of who they are as the patient presenting in front of us, as the person that's presenting in front of us. And so now we're getting towards this idea of cultural competence, and where again, meeting the patient where they're at with things like verbal communication and how we greet them. Is it appropriate for me to look at the patient in the eye, stick out my hand like I'm going to shake their hand, provide physical contact through the handshake, maybe being loud or a little robust with my verbiage? That might be offensive to somebody. That might be intimidating to somebody. That might be derogatory. But the vice versa of that is perhaps avoiding eye contact or not shaking their hand could also be considered rude. So finding that common ground and doing your best to navigate some of these challenges. We could talk about psychological variations, or how spirituality or religious practices come into play. We know that there are some cultures where it's completely inappropriate for a man or a male to treat a female, or vice versa, or to directly interact with a person of the opposite gender or opposite sex. And perhaps eliciting information could be a challenge. You know, the patient may not be okay with providing open-ended responses, that they might be more comfortable answering yes or no questions, or more structured questions in that capacity. We could talk about time orientation. We live in New Mexico, nicknamed the land of manana. Some people are not prompt and timely, and it's not that they don't respect timeliness, but rather their value around time is different than, say, maybe yours as a provider. Thinking about taboo times. Is this a time of mourning? Is this a time of celebration? Is this a time of rest? And understanding that clinical times may not align nicely with these taboo times for certain cultures. So how can I use culturally competent care to advance the advocacy in my practice? Well, let's talk about patient safety first, because at the end of the day, if we're not being safe, we're probably not doing a great job at doing very many other things. So understand that safety is a complex topic. It extends far to the far reaches of the healthcare arena, but failure to address safety from a cultural perspective can also be dangerous. That patient may choose to not seek further care because of a misunderstanding, because of a miscommunication. So understanding that we're all going to make mistakes. We are going to screw up. It is going to happen. I do it as well. And we need to be able to move forward with that, acknowledge it and move forward with it. And I'm going to talk a little bit more about that a little bit later on, but we have to acknowledge our shortcomings to make the patient feel safe. We recognize differences. One of the things that I keep continuing to hear in today's day and age is that I'm colorblind. I don't see differences, or I treat everyone the same. And that's an issue. We have to treat people differently, not because we don't appreciate their differences, but because their differences pose challenges. And that what one person needs may not be what the next person needs, or they might need more or less of something, some kind of social support, whether it's assistance with getting access to care or time with us in clinic because their healthcare comorbidities are more complex. And being self-aware as the provider in the encounter on how to bridge these gaps between all of these different aspects. We want to use active listening skills, things like describing and identifying and then interpreting, and that understanding that interpretations may not be correct. And so we need to verify through different mechanisms, whether it's through verbal or nonverbal signs, and experience honesty at where it's at. Again, being open and honest with the patient so they feel comfortable. So when we look at this from kind of more of an academic perspective, we'll call it, we're looking at this continuum. And I kind of was alerting to this a little bit earlier, but most of us probably sit in this cultural pre-competence, cultural blindness range on any given day with a group of people that might be new to us. We recognize that as healthcare providers, people are different, patients are different, that just because we have 3 ACL tears presenting in clinic in front of us for rehab, that these are 3 very different cases, although the diagnosis might ultimately be the same. And so the goal here is that we want to move towards cultural proficiency. But the reality is that most of us probably will never truly reach cultural proficiency, and that we probably flirt more closely with cultural competence. And that's okay, right? It's like the idea of expertise. We're not going to be experts in everything and all things, but we're going to try our darndest to get to that point. When we stop trying, that's when we start to revert back to this cultural incapacity, or even lower down on the scale here to the cultural destructiveness. And so in order to help us move forward on this continuum, we need to recognize the idea of cultural humility. And again, this goes back to that idea of self-reflection and self-critique, checking the ego at the door, and understanding that everything that a person is plays into their healthcare. The customs, the practices, to the music they like to listen to the traditions they celebrate, to the theater and film that they participate in, rituals, all of this creates the person in front of us, and it needs to be acknowledged. What does it look like from our perspective? Well, it's very individualized. You as the individual provider has to make action happen, but it's got to work within the greater systematic whole, right? I have to address power imbalances, that a lot of people might see me as the provider as this, maybe in some cases, this almost godlike type of entity, when we're not. We're just people, but our patients might see it because of their cultural upbringing, that they're addressing someone of a higher power because they're providing the care. And so we have to break down those barriers. And so when we look again at this kind of from this foundational perspective, I really want to dive a little bit deeper into this foundational level, the cultural awareness, number 5 here. And so one of the aspects of this is cultural intelligence. And so cultural intelligence is this idea that as an individual, as a healthcare provider, or just a person, that I have biases, I have prejudices, and I have assumptions about individuals who are different from me. And while I don't like to have biases, prejudices, and assumptions, the reality is that all of us have biases, prejudices, and assumptions. And so to that point, we have a picture here of what we assume to be is the first Thanksgiving, right? Where, as probably growing up in the United States, we were taught the first Thanksgiving was this joyous occasion where the Indians and the Pilgrims came together in harmony to celebrate their differences and share recipes and exchange food and story and all of these wonderful things. But the reality is it wasn't like this, at least not up front in the beginning. And if you look at this picture, we kind of see from the superficial really quick, we see this kind of harmonious celebration, but we start to really look at this. The artist of this image has depicted a child behind a female figure who is serving food and a terrified kind of face on her. We have the quote unquote Indian sitting at the table looking kind of savage-like. We've got the white people looking rather dignified and European in their cultural responses to the meal. So these are the types of things that exist in our culture, right? This is the narrative we perpetuate, and we need to move past this. And so one of the ways that we need to do this is recognize biases. And so we all have biases, every single one of us, myself included. And a bias is essentially a negative evaluation of a group, or one person or a group, a member of its group. And biases can either be explicit or implicit. Explicit meaning that the person's aware of their biases, and whether or not they choose to accept it or try to move past it is irrelevant. It's just something that they put out there. Versus implicit, which is arguably worse, where they don't recognize that they're operating under this unintentional evaluation of somebody. And so we have to be able to recognize these things in our patient encounters, in our healthcare. And so one of the best tools I've ever seen out there about recognizing biases, especially implicit biases, is through the Harvard Implicit Bias Test, which I have a link at the end that I'll share with you all about how to access some of these resources. But this test, it's basically a series of questions, and it helps to identify biases that you may not have even noticed that exist, thus an implicit bias. But what we do need to do and be active on is to fight these biases, and we need to be able to point them out and be an example and speak up. So being the person who identifies that there's a bias or some kind of stereotype occurring, be an example by providing the correct type of behavior and encouraging an environment where you can speak up and challenge these biases. So as we continue along, we'll look at cultural knowledge, which is the process of seeking and obtaining a sound educational foundation about diverse cultural and ethnic groups. And one of the things that we have got to be better about as a whole, as providers, is the idea of cultural skill. And this is where we're working on foundational skills like communication, but from more of a cultural lens. Again, understanding that a handshake is not acceptable in all cultures, or that direct eye contact is not acceptable in all cultures. And meeting again, once again, where the patient is at. And so from more of a practical perspective, what does this mean? Well, if we practice cultural skills, it helps our patients feel more comfortable, and it helps us to establish a relationship. It helps to maintain good communication. It helps provide information in ways that people can understand and accept. So therefore, it's helping with compliance. It shows respect, right? The patients will come back. They're going to be more likely to adhere to the treatment plan, to the plan of care that we want to help outline with them. It helps them to be flexible and adaptive. And we don't want to make assumptions, right? We want to ask. If we're not sure of something, we need to be comfortable asking challenging questions, but framing it in a way that helps to provide the patient with an open platform to talk about what their needs are. And so we can talk about cultural encounters, the process that encourages people to directly engage in cross-cultural interactions with people from culturally diverse backgrounds. Or even this idea of cultural desire, where we're evolving beyond the thought that we have to do something, but rather we want to be more aware of and understand the culture of our patients because it makes everyone better. So we've talked about all of these different kind of academic components to what moving towards advocacy looks like, but how do we actually put it into practice? And so one of the most foundational ways we can do that is to create a safe space. And so understand that an inclusive environment isn't just patient and provider, right? We have staff that works in our clinics. We have other providers. We have families, friends, loved ones. We have all these different stakeholders that we have to acknowledge because they're part of the clinical environment. And so one of the easiest things that you can do as a provider is market yourself as an inclusive person. One way you can do that is to sign up for the LGBTQ plus healthcare directory. This is a directory that is supported by GLMA, which is a nonprofit gay LGBTQ queer community-based group that supports quality healthcare for the queer community. It is free to sign up. I checked this website yesterday just out of curiosity. There's currently 4 healthcare providers listed in the state of New Mexico on this website. And I can promise you, speaking as a gay man here, that I certainly would be looking at this directory if I was new to New Mexico or new to the area, looking for somebody who I know that I could trust. We could talk about staff trainings, right? A patient walks into your clinic and you are not probably the first person they see. They're probably seeing somebody from your staff to check them in or to take their history or to do whatever it is they need to do. Those people have to be included in these trainings. They need to understand that you need to use appropriate language, that you need to identify and challenge any kind of internal discriminatory behavior, and educate them on important health-related issues and so why we need to do these things. So let's talk about linguistic sensitivity. It is so vital in today's day and age to use gender-neutral language, such as partner instead of spouse, or husband, wife, making sure that we're using an interpreter if necessary, that we know that best practices don't allow us to utilize a loved one or a friend as an interpreter because there could be some sensitive information being exchanged that they don't want to know. Or there could be an abusive situation where that interpreter might be the abuser, right? So best practices is using a third party. And we don't want to be presumptive in our questions. We want to ask non-presumptive questions and invite that open-ended answers where we can to help the patient tell their story, tell their narrative. And one of the easiest things you can do is just utilize the patient's self-identified name and pronouns. I understand that there's some complexities with sex assigned at birth versus gender identity and how they present in clinic. But if someone says that their name is John, I'm going to call them John. And if they tell me that their pronouns are they, them, I'm going to use they, them pronouns. I might screw up. I might misgender someone or misname someone. And we'll talk about this here in a second about how you identify that. But please do understand that these are not preferred pronouns. These are their pronouns. And it is your job as a provider to recognize that that is your patient, meeting them where they're at. So let's just talk about pronouns really quick and why words matter. And so again, individuals who maybe don't subscribe to the gender binary of male, female, or are transitioning maybe from one gender to another, this is where you might see the pronouns coming into play. But also, I mean, I'm a cisgender male. I was born male. I identify as a male. I use he, him pronouns. And I let my patients know that I use he, him pronouns. Back when I used to work in the clinic, on my badge, I had a little button that just said he, him. I've seen it where providers have had this on their office door, or when they introduce themselves, hi, I'm Dr. Schroeder, I use he, him pronouns. So there's all these different ways that you can introduce this in clinic, and it invites the conversation for the patient to say, oh, I'm so-and-so, and my pronouns are X. Symbols are so vital. An image can speak 1,000 words, could not be more truer in this case. And so there's a million symbols out there that you could utilize. I just gave some examples here. So we have the HRC quality sign. In the field of athletic training, I'm an athletic trainer. We have a safe space training that our national professional organization has created. And so at the end of completing that training, you're mailed a sticker. And this is what that sticker looks like. I have this sticker. It sits behind me in my office, so that when I have students come in, they see this sticker behind me. When they're facing me, they know that they're in a safe space. But the number of symbols out there are countless. So this QR code will take you to, for example, the different types of pride flags out there. So anything out there, little things like this make a huge difference for patients to understand that this is a safe space. Thinking about other things though, like the restroom situation. Some of us might work in places where we only have single stall bathrooms. That's great. Does our signage match that, saying that this restroom is for all people, not just males or females? The pictorial representation of these spaces. So for example, with the restroom, this picture you have here has a more male, masculine looking figure, a more female looking figure, as well as this non-gender conforming individual that is present here. So this is one example of how that could be presented in a clinical setting to help promote this idea that this is a safe space, and that we recognize that you have some differences and we honor those through these various means. Remember that we are always seeking patient-centered care, that the patient should have an active role in their care, that the patient is a partner in the treatment plan, and that the provider collaborates as opposed to dominates the treatment care plan with the patient, that the care is about quality of life, it's not disease-centered, and that the provider listens. So what happens though if you mess up? You misgender somebody, you use the wrong pronouns, you maybe don't acknowledge something that maybe they've said. Well, we do something called respectful regrets. And this is where you, as the provider, or really just a person in any situation, acknowledges the discretion and you're aware of it, apologize for it, and then listen. You've got to listen. Why was this such a negative experience for that person, for that patient? And then reflect on it and make an active effort to do better. Body language goes into play with this as well. Don't be closed off. Try not to come off as that. I know sometimes we kind of get caught up in the moment and we can appear closed off, but genuinely have the attitude that I will be better and do better. And with this, you need to understand that you've got to have a mechanism to carry this forward. So again, as an athletic trainer, I see my patients quite frequently. So it's not hard for me to remember, but for someone who may only see a patient once every 3 months, 6 months, a year, do you have a mechanism to make notes in the clinical documentation that says this person identifies as male, uses they, them pronouns, and is that someplace that you can quickly reference to help you do better? So we're moving from ally to advocate, right? That's the process here. We want to be an advocate. And so how do we do it? How do we tie it all together? And so it really comes down to you as personal responsibility. You've got to commit. The work is not going to do itself. This is a constantly evolving science, just like everything else in medicine and in healthcare. You cannot practice the same medicine 20 years ago today. You'd probably get sued and lose your license or something. This is not saying you're gonna lose your license, but everything is evolving. You've got to evolve with it, and you've got to be intentional about it. You've got to seek out opportunities to break down inequities and systematic barriers. And embrace it. It's a journey. It's part of everything else in life, that this is not going to be easy for everyone, and that maybe there's parts that are easier than others, but it's not easy, and you're not always going to have the right answers, and that's okay, so long as you're trying your best and being active in change. Assessing your cultural awareness, huge part of what we've discussed today. And so we work in healthcare, we love outcomes. My gosh, you can't get anywhere now without talking about patient outcomes. And guess what? We've got outcome assessment measures for cultural awareness. And so you could play around with these and assess your own professional competence in cultural awareness. I talked about the Harvard implicit bias test. That's what this QR code will take you to. If you wanted to take some of these, I think you'd be surprised at what you have some biases towards. But ultimately, what we're trying to do is move from reality, which is where we're at, right? Where we've got all of these potential resources in society to aid people and patients, but they're not distributed in an equitable fashion. And so we go from reality to equality, where everyone gets some resources, but it may not be the right types of resources or in the right quantities or at the right time. And so while equity is better than reality, it's not great. So then we're pushing towards equality, where we're getting people the right resources in the right quantities at the right time to give them the supports that they need to live a higher quality of life. But what we really should be striving towards is justice, where we've removed all of these systematic barriers within healthcare and outside of healthcare so that people can live their life without the supports that they would need otherwise. So take-home points here, I'll wrap it up, is use the terms that people use to describe themselves. For example, older individuals back in the day, we may have used the term transvestite, for example, as a term to describe someone who is identifying themselves as a gender other than what they were assigned at birth. And the term transvestite now is rather offensive to a lot of people. But if I have a patient who self-identifies themselves as a transvestite, that's the word that I'm going to use to describe them, because that's their words. Another example could be the word queer. Queer was never a derogatory term, and then it started to become this derogatory term. And then, interestingly enough, the queer community has tried to reassert itself and take the word queer back. And so a person may identify themselves as genderqueer or I'm queer. And the word queer can have a lot of different meanings to a lot of different people. So this is where I would ask in a non-judgmental way and say, well, what does that mean to you? How can I support you as your provider as a queer person? Be aware of your own biases. And again, you have them. I promise you have them. Acknowledging them and trying to work past them is an ongoing journey. Avoid asking unnecessary questions. This can be challenging sometimes, because sometimes we don't know what we don't know. And again, that's where that respectful regrets comes into play when we make mistakes. We want to create an environment of accountability, that it's not just one person carrying the load, that there's not just one DEI person, quote unquote, in the office, that everyone has a responsibility here to make the environment, the clinic, the workspace, a safe environment for all, an inclusive environment for all. And understand that, again, the word ally is a noun, but advocacy, being an advocate, requires the motion of action. And so advocacy will focus on dismantling these structures that oppose that individual or group. So with that, I'm going to finish up, and before I start taking any questions, I just want to mention one more thing, that this is a safe space, as safe as it can be on Zoom, keeping in mind that I guess this is recorded, so safety is limited. But I hope that the discussions that we have here today are good, and I hope that whatever you learn here, you are able to take out into the real world and utilize to improve your patient care. The other thing I'll mention quick is that I am always open to have conversations with people about individual clinical questions or how to things that may not be available to the group right now. I'm totally fine with answering any questions now, later. Please reach out. I'm always happy to have these conversations, and this QR code will take you to a list of various resources to help you be better at providing clinical care.
Thank you so much, Dr. Schroeder. That was a really wonderful presentation, and it's a really great way to wrap that up with a picture of your dogs, for sure. If that's
yes.
not warm and fuzzy.
Yes, Teddy and Duncan say hello. They say Happy Pride Month, and love is love. So
Thank you for introducing them. I was hoping you would. We're waiting on a few questions here, but I was wondering, one, thank you so much for talking about the wonderful cultural skills tips that you presented for us. I wondered if you could just talk to us a bit more about some experiences that you've had where, you know, we might be able to improve the patient experience in having to acknowledge any misunderstandings that were our fault as providers. But, you know, as you mentioned, when patients see other members of the clinic first, right? Because they're all members of the clinic. So when they have a bad interaction or a culturally inappropriate interaction with staff members first, you know, that's going to make the rest of their experience with you as the provider really bad, and perhaps the entire healthcare team. So you can provide some more experiences or perhaps even interactions that you've had where you have to either speak on behalf of the people that they've had those encounters with in the clinic prior to seeing you as the provider first. Like, did you go and try to explain what that bad interaction might have been with the staff before they saw you? Did you try to apologize on behalf of the staff, or how did you try to make that experience better and more positive for them? Because this is obviously going to affect the entire healthcare team and them wanting to come back and seeing you as an ally and seeing the healthcare team as an ally.
Yeah, I mean, first impressions are everything, right? And this is certainly no exception. And so, again, people are going to screw up. And so I would say before it even gets to that point is, have you introduce a culture where people can exchange information freely, you know, or exchange ways to improve freely. And before you just jump to saying, yes, my clinic does that, I really want you to think long and hard, because power dynamics are a very challenging thing in healthcare. So, and again, it's one of those things where there's not a great cookbook approach. You kind of have to know the people you're interacting with. And if it's affecting patient care, it might behoove you to pull that patient aside and say, I see you're kind of upset, or I'm noticing some kind of, you know, that you seem kind of upset. Is there anything that I can address or help to work with you? And kind of dissolve it on a one-on-one basis. They're already in an invulnerable position by just walking into a clinic. Patients are not, most of the time, not feeling comfortable about being at the doctor's office, right? That's a scary time for a lot of people. And so do you have a mechanism in place to address these kinds of things in a constructive manner? And what that looks like can be different from place to place. But I think the first and foremost is understanding that the patient needs to be made to feel safe. And so pulling that patient aside and saying, what's going on? How can I address it? And then making sure that you take action on that and say, I will absolutely address that with the front desk staff or whatever it means. But just having that open communication and being able to say that I recognize that you are not feeling comfortable. I want to make it better. What can I do to do that?
Thank you so much. And Dr. Sanchez also has a question.
Sure. Well, thank you so much, Kevin. That was an excellent presentation, and thank you for sharing your own lived experiences. You know, I often we hear about the role of practitioners in creating a safer space, but a first insult often to people who come to our campuses or clinics are the encounters that they have when driving in to the parking lot, when walking through the doors, when registering themselves and being asked if they fit a binary on a registration form. Can you share your thoughts on how a clinic or a university can work to ensure that even before they enter into our clinic spaces, our patients know that we're creating an inclusive environment? What have you done to transform those paths, and any ideas of where we need to go? Those paths?
And this is huge too, because again, first impressions are everything. And so I think things like diversity statements are very important. We usually bury them somewhere deep on the website, right? Like there's like a little link at the bottom next to the, whatever other things, jobs, careers over here. And then, there's the DEI statement. And we should probably try to create a little bit more of a prominent space for that on the website when they're scheduling appointments or when they're searching for people, right? So there's that almost like a marketing kind of aspect to it, that we are proud to be an inclusive environment. I think the other thing too is people get frustrated is when they go to fill out that initial paperwork, whether they're doing that at home because they're accessing some type of EMR, EHR remotely, or they're doing it, sitting in the waiting room area before going to see whatever provider they're seeing. But again, allowing those patients to self-describe as much as possible, and that you can't just make a radio button of male or female. Like, you can have a radio button male or female, but you also need to have a space where they can self-describe and put it up at the top, because what that tells the patient is that this is important, right? This isn't something that's just buried at the bottom somewhere, that we want to know this. And in the day and age where EMR is everything, everyone's using an EMR. A lot of them can be custom built. And so there's really no excuse why we can't allow patients to self-describe their pronouns or self-describe their gender identity or sexual orientation in a way that captures who they are as a person. So I think it's just really a matter of if really questioning yourself as the provider is, what information do I really need to know? And how can I capture that in a way that is inclusive of the patients that I treat? And I promise you, other people are doing it. So if you get stuck, reach out to peers at other institutions, other clinics, and see what they're doing. And let that start to drive, or ask the patient, say, hey, we're trying something new here. What are your thoughts on it? Did it allow you to kind of describe what you wanted to tell us? Get your feedback from the people that you're trying to meet.
Thank you, Kevin. I have two more questions, and I think we'll have exactly enough time for both of them. The first one is, how have some of the current events in the country, for instance, the transgender bans, drag queen bans, et cetera, affected the LGBTQIA plus patients that are needing healthcare? What's your thoughts and opinions on that?
Yeah, I mean, it's like you can't even turn around without something changing, and it's usually for the worse. It's hard, and it's just this constant attack and a constant affront on the queer community. And it's hard because healthcare is no exception to that. You've got all these gender affirming care bans going into effect, and they look so different from place to place. And it's disheartening. It's frustrating. I think the little bit of glimmer of hope is that we've seen, I think, 2 states now where the state Supreme Courts have overturned bans on transgender healthcare, gender affirming care. So I think there's precedents. I'm not a legal expert, but I think that there's precedents that we're going to see hopefully some more productive discussions on this stuff. But I think the challenges that are really hurting the queer community, especially those that are transgender or gender diverse individuals, is, where do I go for care? The state of Texas and the state of Arizona and Utah, which surround New Mexico, there are bans in place. There's even states like Florida, and I think maybe even Oklahoma, where if providers they cannot provide gender affirming care to a certain extent, but they also cannot refer those patients out to surrounding states or other places, because the provider themselves might be charged as a child abuser or some kind of felony, right? So it's a problem for everyone. And so this is where I'm going to take off my faculty member hat for a second and say, go out and vote, right? Have conversations outside of the clinic, talk to people, say the things that need to be said, be an advocate both inside and outside of your clinic, because this is not hurting just transgender and gender diverse people or drag queens. These are hurting all of us as people.
Thank you so much, Kevin. And this might be our last question unless another one comes in, but I think it'll be just perfect timing. This question reads, in our clinics, we have clinical trials for certain pathology that is sex specific, and inclusion criteria often do not use gender neutral phrasing. Having inclusivity is important in this area. Often transgender patients feel uncomfortable being approached for sex specific trials that they do not identify with, though they are receiving care for that. For example, prostate or ovarian cancer. Is there guidance on how to approach and include this population in a sensitive manner?
That's a great question. And I'm not sure that I have a super great answer to this, but this is what I will say. Understanding that science has its limitations. We can't always create clinical trials, for example, that are inclusive of all populations. That's the reality of science. There's reasons why we might need to disclose or exclude or include certain types of populations within our studies. That, again, that's science. But what I would say is I would encourage people who are exploring, creating clinical trials, for example, or any kind of experiments or research studies that are going to involve kind of this people outside of the non-binary, to look at the WPATH criteria. So the WPATH is kind of the, I don't want to say end all be all entity, but the guiding entity on the best practices in transgender and gender diverse healthcare. And I think the 8th edition of the criteria has just come out. So that would be where I would point you to go. I obviously can't speak to all studies, and I am certainly not an expert on all science, so I can't speak to specific disciplines, but that might give you some guidance. And if it's still not enough to kind of help you there, I would absolutely encourage you to reach out to other colleagues and see kind of what their thoughts are and how to be more inclusive within those specific research trials.
Thank you as well for that, Kevin. I don't see any more questions in the chat unless anyone has any last minute comments or anything for Dr. Schroeder, or would like a last minute question. We'll give it just a few seconds here, and if not, we will end this wonderful presentation today.
Well, I just want to say on behalf of the HSC Office of DI, thank you so much, Dean McLaughlin and Dr. Schroeder, for your important contributions to the month, but for our university. If you haven't done so already, please complete the pre and the post that's listed in the chat box. So thank you once again.